by way of introduction, I mean, for those that haven't already met me, Graham Stewart, I'm a retired pharmacist. Spent 23 years in the British Army, and then spent quite a bit of time in the NHS. So effectively, I retired when I retired from the Army. So I'm no longer practicing, but I do have many years of experience, especially around the regulatory side, which is what I'm bringing to the table here. So if I quickly stick the slideshow up, I have to say thanks to Sam's wife for doing all of the graphic design on this. My initial version was rather bland, so she's made it a lot more colourful. So it's a big thanks for that. Right, let's see if we can get this one up. Oops. Right, it's the wrong slide. The joy of working with multiple screens. Right, can everyone see that? I'm assuming that that's a yes. Okay, so the whole idea of today was really just to sort of throw out a few sort of key messages, key concepts around the regulatory side of things. I know that this is quite a topical subject and quite a touchy subject for a lot of the folk that are attending. So I do expect there to be quite a bit of debate at the end of this. So I'll try and leave as much time as possible for that. So without further ado, let's skip in. So the way that we're looking at doing it, talk a little bit about the licensing. I have no idea what the background for everyone here is, and I'm assuming that it's quite a broad range from a fairly low level up to, and I know that from the conversations we had, there are a few folk here that are particularly knowledgeable on the subject. So please forgive me if I seem to be preaching to the converted or saying things that the majority know. I'm trying to cover quite a broad base as a baseline to be taking things forward from. So start off a little bit around what medicines are, legally, how they're classified, and then move into a little bit around the administration, sale, and supply. So that's the nuts and bolts, I think, that really interests you guys. And then I'll cover off a little bit around the wholesale dealing, which is where Sam and I are looking at going with this. So as he said, we're not looking at doing it as a pharmacy supply. We're looking at setting it up as a proper, fully registered wholesale operation. And that brings with it some constraints. So I'll try and talk you through them. There's an awful lot of stuff that we won't cover. The misuse of drugs regulations is one. There's an awful lot in there that just wouldn't fit into this particular time slot. So if you'll excuse me, I won't touch on that. But if anyone wants any more information on that, I'm really happy to engage. And we might actually be able to set up a separate session downstream for that. Okay, so diving in, human medicines regulations. Now, the original legislation around this was the Medicines Act 1968. That's still in force. It hasn't been rescinded, but in 2012, the human medicines regulations were made to expand upon the Act and bring it up to date with a lot of the stuff that was going on around the sale and supply, particularly, and the wholesale dealing of medicines in the EU environment. And I know that Brexit's happened, but unfortunately, we haven't yet removed those EU regulations from our regulations, so they're still relevant from a legal perspective. Now, the key point really for human medicines regulations is that they operate on a prohibition and an exemption basis. So basically what that means is they say that you're not allowed to do anything except where these exemptions apply. And basically that, as an example, it says you cannot supply a medicine to a patient except on the direction of a doctor. So that's basically a named patient direction, unless it has a specific legal class that exempts it from prescription only rules. So think GSL and P, or the supply is done by a specific class of person. So these are the paramedic exemptions, or there's a patient group direction enforced, and that brings with it all of the PGD issues and constraints that you guys I know are really frustrated by and are wrestling with immensely. So that's how the basic principle of the legislation works. Basically, it says you can't do anything unless there's an exemption that allows you to do it. It doesn't permit, it just exempts you from that prohibition. So in order to understand what you can and can't do, you really need to get your head around the exemptions element of the legislation, and that can be quite tricky. Licensing, absolutely key thing, and like I say, I don't know about the background for everyone, so excuse me if this is a little bit Mickey Mouse. But basically, all medicines are classified as basically a substance or a combination of substances that are administered to humans for certain purposes. So if they're marketed with a health claim, they're a medicine. Or if they're used particularly to physiologically or pharmacologically modify the body's activity, they're a medicine. Or if they're used to make a medical diagnosis. Now, the medical diagnosis bit can sometimes be a little bit confusing. Pregnancy test kits, it's a diagnostic activity, but the key is they're not in vivo tests. So if you're administering something for the purposes of obtaining a diagnosis, and I've used the fluorescein eye drops there as an example. So you administer them into the eye, they make a change, you look at that change and you can determine whether there's a physical injury to the eye on the basis of that. So because you're actually administering that product to an individual, you're introducing it into the body or onto the body, then that makes fluorescein a medicine, but COVID test kits are not. What are not medicines? Well, I mean, I could be here all day defining that one, but broadly speaking, it's all of the equipment, all of the ancillaries that you would use in your clinical practice, your syringes, your needles, all of that, those are devices rather than medicines. They're controlled under the medical devices regulations. And as I say, the in vitro medical tests, so your COVID test kits, your pregnancy test kits, things like that, your glucose test strips, those are all considered to be devices rather than medicines. Blood and blood products, not particularly relevant to this group, I know, but basically those are excluded as well. They're not medicines unless it's an immunological product that's derived from blood, which then does become a medicine. And the key for all medicines is, if it's a medicine, it has to be licensed. You're not legally allowed to manage or distribute or supply a medicine, with a couple of exemptions, unless it's got a license. So absolutely critical. If you're looking at anything, if it doesn't have a product license on it and it falls into that category of a medicine, then you probably shouldn't be touching it with a barge pole. And the key really for the marketing authorizations or the product licenses is that they are absolutely specific to the pack. So if it's a pack of 24 paracetamol, it'll have a particular product license. If it's a pack of 32, it might have a different product license. The packaging is as important as the drug when it comes to the marketing authorization. Key one really, if it's a composite item, so if something is incorporated alongside other products, and I'm thinking alongside sort of dressing packs, first aid kits, that kind of thing. If there's a medicine put into that pack for it to then be supplied onwards, then it falls under the requirements of the medicines regulations. Yeah, so it effectively becomes a medicine. The composite pack itself becomes a medicine according to the legal class of whatever it is you've put in. Let's say Unicept sachets, chlorhexidine gluconate, they're a P medicine. So if they're in a pack, then the whole thing becomes a P medicine. Thankfully, Chloroprep is a GSL, so it's still a medicine, but it's no longer controlled in the same way. But Normasol is considered to be a medical device, strangely enough. So it's not a medicine, it's a medical device. So that can be freely incorporated into packs without bringing in the medicines regulations as a constraint on how you supply them. Okay, so broadly speaking, all medicines, well, not broadly speaking, in fact, all medicines will fall into one of the three categories that we've mentioned. So GSL, P, and POM. GSL can be sold, supplied to the public from any location. So this is your high street supermarket, your garage forecourt, any of those. They can all be supplied from any location. P medicines can only be supplied or sold and supplied from a registered pharmacy, which is where we're going to hit some problems further down into this presentation. POM, prescription only medicines, they can only be supplied to the general public under a prescription. So this is a written instruction given by a doctor or a dentist or various other appropriate practitioners. And the key point about prescriptions are they are for the individual. So they're a named patient supply. You can't give a prescription on a general basis. The categories there, as I say, they're specific to the MA, marketing authorization. So something may be particularly packaged to be sold over the counter in your local Waitrose, and the exactly the same product or exactly the same medicine could well be packaged differently and have a P classification, for example. That quite often happens in terms of the size of whatever it is that you've got the authorization for. Tubes and ointments, you might find that a small size of a tube is a GSL product, a larger size becomes a P, and an even bigger size could even be a POM. So, the categorization of products is very much tied around that whole product view. And then, as I say, if you break the packaging, because the MA is specific to the pack, if you break the packaging, then you effectively invalidate that marketing authorization. So breaking strips out and repackaging them into a composite item would effectively be incorporated in an unlicensed product because it's separated from all of that other stuff that goes with the marketing authorization, the outer packaging, the patient information leaflet, all of that stuff ceases to be part of the product, and therefore the product would be unlicensed in that respect. So there's a couple of definitions that I wanted to just throw up, just so that we're all on the same page. So you hear the word supply being used frequently, and that means to give it to somebody, to actually physically hand it to somebody for them to take, to swallow it, or administer to themselves. So they basically take it away and use it. Supply to somebody who will then supply it onwards. So that that's applying to an intermediate person, that becomes wholesale dealing. So you fall under the requirements for a wholesale distribution authorization, which we'll cover later on. The exemption to that is if, for example, I supply Mr. Jones with a product as a company, and Mr. Jones then gives that product to individuals within his company, so within his organization, that internal distribution doesn't count as wholesale dealing. And then we also have administration. Administration is such a tricky subject, but this is basically the physical act of either putting it into somebody's mouth or putting it onto the skin or injecting it into them. So you are doing something to introduce that product into or onto the person you're treating, and that's counted as administration. Now, a key point is basically who can administer a medicine, and this is really, really, really tricky because the Human Medicines Regulations don't really go into a huge amount of detail around administration as a function, as a concept. And really it's driven, the who can do it is very much driven by who the individual is, what the product is, the circumstances that they're doing it under, whether there's a PGD in place. So there are no clear generalizations that you can make. It's very much down to the specific circumstances around, as I say, the product, the circumstances, the individual. So it can be a really tricky one, the administration bit, but there are a couple of bits that I'll get to later on, which hopefully will give us a little bit of a way through the woods and possibly a light at the end of the tunnel for administration, certainly. Now, there are some general exemptions, and I'll talk you through them just as a way of bringing everybody up to the same knowledge base. But the original exemption from prescription-only medicine regulations was built into the original Medicines Act 1968, and it was predominantly around emergency use. Now, emergency use in those days was responding to things like terrorist attacks. There was obviously a big threat or perceived threat of attack in the UK, and a lot of products were perceived to be of use in the event of those circumstances. So most of the ones that you see there are for the treatment or the response to a chemical, biological, radiological, or nuclear incident. So your pralidoxines, things like that. These are all your nerve agent antidote products. There are a couple that I've highlighted which I think are still relevant in the context of what you guys are doing. So in that emergency, the event medical and pre-hospital emergency care scenario, so those exemptions there, the adrenaline, the glucagon, the glucose, and the naloxone, can still be relevant to what you do. And basically, anyone, irrespective of their background, training, professional registration, anyone can administer these parenterally, so they can inject these products. Now, that's not to say, and we'll get onto the how do they get a hold of them a bit further in, but that is the exemption that allows people to administer the products to someone else. The next one, all of these slides we'll share with you, so I'm zipping through to make sure that we've got enough time for a chat and a conversation at the end of it. So I won't read the slides out word for word. You can have a look at them, and if there's any questions further on down the line, come back to me by all means. So in terms of the classifications, so GSL medicines, general sales list medicines, there are no restrictions in the legislation around who can sell or supply these. So, if, for example, you were setting up a tent, this might sound a little bit Mickey Mouse, so don't be offended if I sort of understate what you guys are delivering. But say, for example, you were setting up a tent providing event medical care at, I don't know, an air show, for example, then technically you probably would need to explain why you didn't have a building surrounding it, because technically the legislation does refer to buildings. But I think you could argue quite safely that that tent that's permanently manned with a lockable box inside it is sufficiently secure to be able to satisfy the regulations on the GSL side. Assuming that you're only dealing with products that are in their original packaging. Pack size limits will drive the marketing authorization and the legal classification. So you don't need to remember or focus too much on whether it's a pack of 24 or a pack of 36. As long as you stick to a GSL labeled pack, you will be meeting those pack size restrictions. And like I say, I think as long as you can assure or ensure sufficient security of the goods, the whole idea of the building is to prevent unauthorized access. So as long as you've got sufficient security around your stock, I think you could certainly argue that meets the requirements. E-medicines, and I know that this is such an emotive area from the conversation that we had previously, and I know that there's a massive amount of crossover and interest in the P sector. I've tried to keep it very, very simple here. We can go into it in a bit more detail later on if the conversations drive us that way. But basically, P medicines can only be sold or supplied from a registered pharmacy. The exemptions to that are basically the sale or supply against a prescription. So this is a named patient prescription, or the sale or supply under a PGD. Those are really the only current exemptions from that P medicine pharmacy only restriction. And then next one. And then your prescription only medicines. I mean, you all know these, but basically they can only be supplied, sold or administered with that exemption to this general exemption I mentioned earlier on, in accordance with the instruction given by an appropriate practitioner. An appropriate practitioner is defined within the legislation. So that's your doctors, your dentists, your prescribing pharmacist, prescribing nurse, and supplementary prescribers as well work within that general categorization of prescribers, except the administration in emergencies, that's Schedule 9, but also the PGDs come in here, and then we also bring in the Schedule 17 regulations around the supply by the administration by paramedics. And the key point here is that it's administration by paramedics, it's not supply by paramedics. So that Schedule 17 doesn't give you the permission to be able to give somebody something that they will then take away. You can administer it to them, but you can't supply it to them. And also there's another exemption in there which relates to ALS qualified individuals, which is just purely adrenaline and amiodarone, nothing else. Okay, so this is the appropriate practitioner bit. So basically doctors, dentists, nurse, pharmacist, independent prescribers, they can authorize the supplier administration, GSL, POM, not a problem. They can do it themselves or they can authorize someone else. So somebody want to come in there? Yep.
It's just me, just bothering you. Gareth in the chat just asked a question a second ago on your previous slide about even if the individual is an independent prescriber. I just wondered if you could cover that off, sorry, while we're on that slide.
Yeah, so appropriate practitioners, independent prescribers, doctors and dentists are automatically classified as independent prescribers. Nurses, pharmacists, paramedic independent prescribers. Sorry, I missed. That's what it is. I missed the paramedic independent prescribers off of the list. But basically, if you're an independent prescriber, you get the rights to prescribe. Doctors and dentists get them automatically. Does that help?
Yeah, that's amazing. Thank you. Sorry, Graham. I was just trying to clarify as to where we stood. That's great.
No worries, buddy. Sorry. Yep. Okay. So yeah, this is the appropriate prescriber, appropriate practitioner. So say doctors, dentists, nurses, pharmacists, if they're registered as independent prescribers, paramedic independent prescribers have a couple of restrictions, but broadly speaking, they're in the same category as the rest of them. Key point really is appropriate practitioner prescribing is patient specific. So you've assessed the patient, you've determined what their need is, and you're authorizing the supply or administration by someone else or doing it yourself for that specific patient. So you've taken control of the decide act process, and the two of them are within your control. excuse me, which then neatly brings us on to patient group directions. These basically allow for a non-patient specific direction. So the patient doesn't need to be individually identified. These can be identified by group, and usually it's by inclusive class. So you would say, again, just throwing this one, left-handed individuals are included, right-handed individuals are excluded. So you can operate the PGD on left-handed individuals, but you can't operate it on right-handed individuals. So the whole definition of the group is by certain criteria that are common to that group, and you could do it as must have a positive COVID test as one example. Blood pressure of a certain level, heart rate of a certain level. These could be inclusion criteria that would then make someone eligible to be treated under the PGD. Key point is only certain individuals currently, and the word currently is important here, only certain individuals currently are allowed to operate under PGDs. And this is in the law. And those classes of individual who can operate are basically registered healthcare professionals. And it's not all registered healthcare professionals. Basically, if you're registered with the NMC, HCPC, GPHC, those kind of registrations will be acceptable. Unfortunately, ambulance technicians and healthcare assistants are not currently classes of people that are eligible to operate. There is a consultation out at the moment, which is looking at pharmacy technicians being included. They're not currently in there, but there is a consultation running to extend the permission to pharmacy technicians. And I would suggest, I'm probably anticipating a little bit of the conversation, but I would suggest that as a group, you might want to think about whether or not there are cases that you could make for inclusion of other groups. The medicines and medical devices regulations 2021 give the Secretary of State permission to vary these inclusion criteria, these groups that can come in. So it's under those regulations that the Secretary of State would potentially authorize additional classes of individual, but the case would need to be made for that inclusion. Key point about authorization: a PGD is just a bit of paper until it's authorized. The authorizing bodies currently defined in the legislation are, largely speaking, NHS organisations. So that's NHS secondary care, NHS primary care. So yeah, in the context of this group, if you're an ambulance service provider who's delivering something on a commissioned basis to an NHS secondary care organisation, you would generally be expected to use their PGDs, or they would authorise the PGDs that you put in place within your organisation. There are permissions for independent organisations, so an independent hospital, an independent clinic, and then this last one, the independent medical agency. Those are all authorised to be, they're all permitted to authorise PGDs themselves for their internal use. And really unhelpful, I know, is that medical agency in England is defined as somebody who's registered with the CQC. Now, that brings with it some challenges. I get that. I absolutely get that. But say I'm sticking purely to what the law says here, and then we can work out how to deal with the more the left and right of ARC as a result of that. Medical agency. So say it's a group or an organisation that has medical practitioners delivering services within it. So it could be an organisation that's set up by medical practitioners. It could be an organisation that employs medical practitioners. But the term medical agency involves the delivery of services by medical practitioners. That's inherent in that definition. Where the individual sits within the organisation, there's a whole raft of legislation out there around responsible persons for delivery of healthcare, and the business relationship or the place within the organisation is usually defined within those regulations rather than the medicines regulations themselves. So there's a whole raft of other legislation out there that applies to that. But in broad terms, GSL products, they don't need a PGD, a written policy. You know, if you're going to be administering them as part of an organisation, a written policy, I think, is probably the absolute minimum that you need to have in place just to define good practice and ensure consistency of approach. P's currently need a PGD unless it's through a pharmacy. Administration itself doesn't need a PGD, only supply needs a PGD. And I'll get onto this administration bit in just a second because I think this is the light at the end of the tunnel. PGDs can be used by the independent sector. There are restrictions on which elements of the independent sector can actually authorise them and put them in place. And the decision process, this decide act bit, cannot be separately undertaken. So if you're authorised to operate under a PGD, you're given the permission to make the decision and do the action. You cannot delegate that action to somebody else. Yeah. And as I say, the undertaking this medical agency, it doesn't need to be run by doctors. It just needs to include the services provided by them, and that will generally automatically bring them under the auspices of the CQC's inspectorate, or the equivalent in Wales and Northern Ireland. Sorry, I should, in Scotland, Wales and Northern Ireland. Sorry, I should say that. Okay, so this is potentially the light at the end of the tunnel bit. There is a lot of discussion and there's a lot of published information around homely remedies. Homely remedies are defined as products that you could obtain and use at home without having to get a doctor involved. So these are the P stuff that you go and buy from a pharmacy, or the GSL stuff you would go and buy from your local Waitrose. There's a lot of guidance out there, an awful lot of guidance around these homely remedies, very much pointing towards the care home environment. So, you know, they have to caveat that, yeah, that's where all the guidance is formed, but it might offer an opportunity for some organisations and some individuals working within those organisations to be able to interpret these rules for their own purposes. But basically, I've given you a few links there. You can pull them up when you get the slides. In effect, what the homely remedies does is it says you can authorise somebody to administer a homely remedy, so a P or a GSL medicine. The difficulty is, like PGDs, it does require somebody who's a healthcare professional to effectively make that decide process. So the way that this is currently presented in the links that I've given you there, it does require somebody to pre-authorize the supply. So, you know, think of it as example as the matron in a nursing home. When, you know, Mrs. Jones arrives at the door, the matron can assess her and say, right, that individual can have the hydrocortisone cream, she can have the paracetamol, she can have the, you know, the antihistamines, and those are all recorded for the healthcare staff within the care home to then administer to them. So there's that pre-authorization bit. Not particularly helpful, I know, but as I say, there's something here that might help get around some of these P restrictions that are particularly troublesome for the sector. So have a look at those. So we can't, I can't say to you, go and do it under that, because that's not what Sam and I are in the business of doing. All we're doing is making you aware that that is there, and it might offer an opportunity for you as organisations to be able to work that principle into your own practices. Yeah, we can't recommend that you do it, but we're just making you aware that that is there, and it offers an opportunity for you to investigate. So, okay, having gone through all of that, I mean, these are the problems that I perceive. I may be completely off beam here, and I dare say that you guys will probably come up with a lot more. But broadly speaking, the legislation allows GSL stuff. The legislation doesn't allow, unless you're a member of an organisation that's approved to do it, or if you're a member of an inclusive group of professionals, then you're not currently eligible to supply P medicines. So that's a big constraint for what you want to do. And I think that's something that the sector as a whole probably needs to engage with, especially if you're starting to think about legislative changes. You're going to need to get quite a significant support group to guide that legislation through, and I'm quite happy to talk about how that can be done. But as I say, you're going to need to start engaging with this as a sector rather than as individual organisations. And that takes us on to wholesale dealing. So this is really where Sam and I are coming from. So this is, this is the legislation that says, or constrains us in what we want to do. So we are looking to sell or supply it to organisations. We're not looking to get into a retail scenario, so we're probably not going to be supplying to individuals. But there is no clear definition of the organisations that we would be including, as long as they have a legitimate purpose for obtaining the products. Then we can certainly look at creating them as customers. The only problem is that we would need to then start looking at the specific products that we can supply to different groups. For example, if you don't have paramedics or doctors within your organisation, then we would have real difficulty supplying you with P or POM products, but there would be no issue with supplying you as an organisation with GSL products. And I know that there's questions around whether or not the range of GSLs is what you need, but we can deal with that separately. So, yeah, so broadly speaking, GSL products to organisations, but not individuals, because we're not on a retail basis. And sell P and POM to organisations that have a justification for their use, and only individuals of Schedule 17 class, so these are effectively the paramedics, would be able to use a non-business account, because the legislation specifically says that they can order them for retention at home effectively. So that we'd be perfectly within our rights to be able to supply Schedule 17 products to paramedics for their own sort of professional use. Now, in terms of how we would validate the customers, and this is what Sam was getting at earlier on, we would look to bring organisations on as customers rather than deal with them as individual orders. So once a customer is approved, then we wouldn't be needing that doctor's signature on every order that gets placed with us. We would probably need to look at whether or not we can validate the organisation. So if the organisation is registered with the CQC, that's a no-brainer, easy enough to bring them on. if they're not registered with the CQC, and I appreciate that there are certain organisations within the sector that elect not to be, and I know that the exemption exists if you're dealing with smaller sporting events, that kind of thing. And what we've come up with is a proposal that we get somebody who is a healthcare professional to certify the business. So this isn't signing the orders, this is certifying the business as being a business that provides event medical cover. So it's their professional registration that's standing behind it, but they don't necessarily need to be a part of the organisation. We're not looking for somebody who's actually embedded in, so you're not talking about every organisation suddenly needing to create a clinical director post, but they would need to get somebody who's a registered healthcare professional to validate their role in providing that kind of service to the general public. Okay, there's a whole pile of stuff that I've taken out. I did have quite a few slides around the specific requirements for PGDs. Happy to go into them probably as a separate session if you really want to get into that level of detail. But failing that, I'm quite happy to sort of pull stumps on the presentation and see what questions are there. Okay, so I'll just get rid of this one.
Thanks, Graham, for going through that. I've not given you an easy task of probably. I think it's fair to say covering one of the probably hottest topics in this industry in sort of 45 minutes. I think kind of before we dive into general questions, I think it's just good to sum up that I think there's a lot of people that aren't doing it properly currently. I know when I used to do event medical cover in the past, I was just told, go down to Tesco to buy, paracetamol, ibuprofen, etc. It's all very relaxed. And I think what our aim is as an organisation is to set this up in a way that we can provide a realistic solution for all of our customers to be able to do it in a proper way and not necessarily spend more money by buying paracetamol and ibuprofen from us, but to be able to provide that kind of reassurance that all the kind of batch recall elements are in place, that it's all tracked and we've got that kind of documentation bundle behind it. And I think like I said at the beginning, when I shared this in a WhatsApp group, I got told as long as we can do it in less than 10 days, which is what one of our competitors is doing, we'll probably do all right. And that's what we aim to do, but also aim to set it up in a way, like Graham said, so that it's the organisation that's qualified, and then we can supply perhaps a wider range than just relying on a paramedic's registration or signature, or a doctor's registration and signature for the order. So yeah, I'll shut up and leave you to the questions, but just to say thanks again from me, and take cover, I guess, probably for incoming questions from the group. I know that I know Gareth raised a question earlier on, which I didn't flag at the time, and he messaged me separately just about the difference between supply and prescribe. And I think particularly, Gareth, if I'm not wrong, about whether you can prescribe and then supply if you're an independent prescriber at an event, and also the person supplying it to the patient. But Gareth's going to get on his paramedic independent prescriber soapbox, as I've been telling him, and tell you off for not including them in your PowerPoint.
I'll take the slap on the wrist for that.
No, I don't want to bore you. It's just an interesting point of view. I think from, paramedic prescribers are getting more renowned, which is brilliant. But when obviously we're working at events, it's very unclear in a grey areas to say, for example, I get some amoxicillin from yourself as from Reflex Medical for the purposes of a chest infection, and working at an event, someone comes into the medical centre that sounds like they've got a lower respiratory tract infection that is very suitable for some amoxicillin. Now, as a prescriber, we would normally generate an NHS, we'd generate an FP10. But how does it work when we're doing events? Can I see that patient and prescribe the amoxicillin that you've dispensed to us on the factors? Because obviously we're not supplying it as such because it's not an immediate medicine, is it? We're prescribing it. But what does our audit trail look like for people that we're doing?
The first thing I would say, and you'll the more you get to know me, the more you realise I can be a little bit of a pedant. So excuse me if this sounds a little bit over the top. But no, we won't be dispensing to you. We'll be supplying to you under wholesale distribution authorization. It's a subtle distinction.
Yeah.
But it's worth just bringing it out. So if you write a prescription, that prescription needs to be dispensed. Yeah. So technically, you could give the individual a prescription for amoxicillin, and they could leave the event and go to the local pharmacy and get it dispensed. That's technically what would happen. What you could do is you could administer a starter dose and give them a prescription to then follow up on that. So you could initiate the treatment through administration, which you would be perfectly within your rights to do, and then give them a prescription for supply, if that makes sense. Yeah, does that help?
It does. It's just like it's getting the right terminology, as you said. So we would always need to generate an FP10. Is that right?
Yeah, for supply.
Yeah.
To give them something to take away, then yes, you would need to generate an FP10.
Cool. Is that something that Reflex could start to do some templates for all of these organizations? Because I know it's got to have legally, it's got to have it, but trying to get a prescription pad that's not NHS is really quite troublesome.
FP10s are legally tied to the NHS. So there's absolutely nothing that we could do for you in terms of FP10s. But as a paramedic independent prescriber, you can generate private prescriptions.
Okay. So
you could give the individual a private prescription, so not an FP10. They then take it to the pharmacy, but they would then need to. It would be treated as a private prescription, so they would pay. It wouldn't be treated as an NHS supply in that sense. So you could, I mean, I don't see any reason why you couldn't do that, but I can certainly look into it in a bit more detail. But yeah, that seems to me the sensible way is you give them a starter dose, you administer a starter dose, and then you give them a prescription to then take away and get a supply.
But we couldn't give them the starter dose and then give them the rest of the box. Is that right? Just so it's clear in my mind. No.
Technically, no.
No. Okay. Thank you.
Got a quick question for you, actually, if that's okay, around GSLs. So it's a debate I often get into with people. So you get into...
that's worrying.
No. Well, it'd be just good to hear an external view because we're quite strict. So you often go to an event and you'll find somebody with something like a threat-free certificate giving out paracetamol and ibuprofen. We don't allow that because if you haven't done it in your course, why are you doing it in your practice? And so it'd be just good.
Point.
But obviously you buy it and people hand them to their friends. So we don't allow it. And we basically say, if you're not a prescriber, you ain't dishing out any sort of medication. That's our policy.
Yeah.
Even though you're not technically prescribing, you're supplying when it comes to GSLs. But obviously you need the insurance to say you're allowed and the certificate say you can. And if you're missing either one of those pieces of paper, don't do it. So I just wondered what your take was on GSLs by people that haven't actually done it in their qualifications, like these threat-free people and first aiders and whatnot.
I mean, the legislation, again, it's going back to this, the legislation says, and the reality is, the legislation basically says there is no restriction. So from a legal perspective, they're not doing anything that's wrong. However, if they're working for you as an organization, then there's a vicarious liability that would sit with you as the employer or the commissioner of their services if they're a locum or an independent. So it boils down to whether or not your organization wants to approve that activity. So legally, they're absolutely fine, but do you want to carry that responsibility as an organization? And that I can't give you any direction on. That's purely down to your organization's internal processes and policies.
Yeah, that's our policy, but we have had a few debates with people. For instance, you know, because I haven't done it on their course, you know, and they give paracetamol to somebody with a liver issue or ibuprofen to somebody with with a stomach because they haven't asked the right sorts of questions, then, as you say, it's a liability issue.
Yeah. I mean, that's where I think the absolute minimum of some sort of protocol, some sort of written guideline for GSLs would be where I would be sitting, you know, excluding things like, you know, if somebody comes in and they're looking a bit yellow, then they don't get paracetamol. Yeah, I'm being a bit flippant, I know, but you get the point. So no, I think if you as an organization, you don't want to go there, then I'm not going to say to you, you should be going there. If you did want to go there, then, you know, potentially you probably need to write some sort of protocol or guideline that gives them the guide rails to work within whilst they're doing that on your behalf.
Thanks.
Deathly silence. First time I've ever seen Matt not talking. Have you frozen there, Matt? Have you frozen?
I'm just talking using my keyboard rather than my mouth, but you know, same thing.
Oh, Matt Graham's got the hang of you in 1 hour conversation. It's
Oh yeah, I totally agree, Sam. Yes.
Yeah, please shout out if you've got any questions. I put Graham and my emails in the chat. I think Graham is the kind of person that will probably be quite modest in expressing his knowledge, but you know, Graham did, I think it's fair to say, was part of the team that wrote the PGD legislation.
Yeah, back in 2003.
So, yeah, so there's definitely a font of knowledge there. Obviously, there's an element of Graham can't go into everybody's individual queries to loads of depths, but I know he has said that he's happy for us to kind of set up meetings on a consultancy kind of basis with customers to help them around this. We are going to produce some templates and things as well for PGDs, what perhaps a medicines administration procedure, for want of a better word, for those GSL meds could look like. Again, it's not saying that you have to do that, but I think it's fair to say that a lot of our customers would benefit from some guidance of what good practice would look like. I've just seen that Martin there in the chat, Graham said, if PGDs are currently for HCPs only, is a written policy for the medication suitable for non-HCPs like techs and first responders, which I think is what we've just been saying is
it's the old
an option.
Yeah, I mean, certainly for P stuff, I think that's on the table. Yeah, in previous lives, I've come into contact with a lot of, you know, especially doctors, and this isn't a dig at doctors in any way, shape or form, but there was a perception that because you were a prescriber, you could in some way authorize others to do stuff and take that liability on to your own shoulders. Technically, within the legislation, that doesn't exist. You know, it's the old story. You know, I drive a motorbike. I can call it an airplane, but it doesn't mean that it's going to get above 10,000 feet. You know, you can call it a protocol, but if it's to all intents and purposes a PGD, then it's a PGD. Doesn't matter what you call it. You know, it's what it's doing and how it's doing it that's the important bit, and that's where you will fall over.
Yeah, and I think some good questions that definitely is not the first time I've heard them. Is how does an NHS trust ambulance technician, so non-registered HCP, administer salbutamol, which is obviously inhaled POM?
Yeah.
Thoughts?
A long time ago, there used to be provision for the administration. That's really where that administration bit comes from, the exemptions, where you could effectively administer anything for the purposes of saving life in an emergency. That has now gone effectively. That was part of the original Medicines Act, and it hasn't been carried forward as part of the 2012 regulations. So no, I think it would be for the individual ambulance trust probably to take that one up with their NHS PGD authorisers. I'd be uncomfortable going any further than that, to be honest.
Okay, it's Teflon Graham's answer to that question. I think just for the purposes of time, as much as anything else, I'm just going to float these. So medication that's covered under the FREC 4 qualification with the safe administration of life-saving medications qualification, which I think, unless Graham's going to correct me, it still all comes back to that organisational policy and the legal status of those medications and the context under which they're given. Obviously, if they are life-saving medication and they have that exemption, then that is okay.
I mean, just picking up on that one for a second. Like I say, I definitely think that there is scope for modification of the regulations. I don't think that the regulations particularly take account of the scenarios that you guys are working in. Now, if you were to define one of the classes of individuals that can operate under APGD, even if you restricted the range of products to somebody who had a FREC qualification, as long as that is put into the legislation going forward, then that covers you. But at the moment, the FREC qualification has no relevance within the human medicines regulations. It's not recognised as a professional sort of inclusion criteria. But that could be changed. That's the key.
Yeah. And I guess, Martin, at the moment, that FREC plus SARM bit is probably more about proving competency if questions were asked subsequently, and I think rather than changing the legislation behind it, I think that's fair to say. Sorry, Matt, I spoke over you.
No, I think this has come up a few times, and it's certainly not an overnight thing. But I keep reconsidering our industry, and in light of major incidents, in light of the Purple Guide, and in light of conversations like this. And the more I think about it, the more I think we do need a way of coming together as an industry for a purpose, and I think that needs to be clear. I mean, I've already said to Sam I'm going to meet him on the evening of ESS. They were whatever day 1 into day 2 is. I can't remember the days. I'm going to say if people are interested in being part of something or having an initial discussion around what, as an industry, what people think that should look like, I'm happy to facilitate that and start some discussions and start putting a document repository where we can all share ideas and then look to take that further. Graham, we will undoubtedly need your kind of guidance for how does one actually then take that forward to legislators and produce that, at least begin that process that way. But I'm certainly happy to do the sort of legwork of bringing people together and having sort of that shared space where we can begin those conversations and then kind of feedback to people with, we've been tasked to find this out. Okay, here's what we found out. Let's discuss it again type thing. So I think if people are at ESS, make a point of coming to find me, and I'll have a think about, once I've coordinated my life with Sam a bit better, maybe find somewhere, Resorts World or something where we can all go and have a beverage and have an initial conversation.
Yeah, but certainly if you are thinking about potentially trying to change the legislation downstream, then you really need the pressure group behind it. And if you can enlist the aid of the Royal Colleges, then that's always going to give you more credibility in that forum. I'm not saying that you don't have credibility now, but when it comes to the legislative changes, if you can get any of the Royal Colleges behind you, then that would certainly give you a lot more of a voice.
Just conscious of the time as well. Sorry, not to move past that point, Matt, because it is an important one. Ryan said in the questions, Graham, so in order to provide a tech/para drug pack to paras/techs for events, what's going to be the best practice of sorts? Seems like you could have a paramedic purchase the range of drugs for your organisation. Would there not be a stumbling block in other staff then possessing the drugs?
Possession's a bit more of a tricky subject. But technically, if you're working within the organisation, I mean, think of the ambulance technician that's got product on his van, for example. You know, technically he is in possession of those medicines whilst he's driving the van. You know, there might not be a paramedic or you know, a qualified individual sitting next to him. So possession itself probably isn't the issue. It's whether or not the individual can use the product. That's the key.
And we can go over these in more detail, like I said, if they need answering. Can prescribing clinicians give verbal orders for medications outside of a standard paramedic remit?
There's nothing in the legislation that prevents it, to be perfectly honest. But you would need to think about the clinical risks of doing that. So, you know, for a start off, any verbal instruction can be received incorrectly. So you need some mechanism to make sure that what is being transmitted is being received accurately. You need to have some mechanism to make sure that it's recorded. You know, so the governance around verbal instructions is the key, really, rather than the legislative permissions or barriers to it. And I think verbal instructions are full of potential problem areas. And I would strongly advise you not to go down that route if you can possibly avoid it. But yeah, I mean, technically, if a paramedic is dealing with 15 casualties at a mass cas event, I don't think anyone would criticise them for turning around and handing off an adrenaline syringe to one of the techs and saying, put that into patient 3. The circumstances are really going to be where the test of that lies, but I wouldn't suggest that verbal instructions are the norm by any manner or means.
Graham, what I was thinking, I think Matt's answered it just very quickly. Obviously, within the Medicines Regulation Act, that paramedics standardly can't give like chlorphenamine and stuff like that. So if I was working from an event director point of view and a paramedic rang me up and said, look, I've got someone presenting with urticaria, their observations of this, are you happy for me to give it? Can I give them that verbal order? I'm not necessarily thinking about like unqualified members of staff. It's more of just thinking outside the box for people, paramedics working where, because salbutamol, for example, is a medicine that you can't give for paramedics as standard.
I know, it's a bloody nightmare.
It's mental. So madness. In a case of like anaphylaxis or an asthma attack, if they're working an event, it opens up a whole world of problems. So if they were able to clearly articulate it on a recorded line with the presenting complaint and bits like that, would we? I don't expect it. I'm not going to go back and say Graham Stewart said back on the 22nd of August. But
it's okay. I don't mind that. But I think
as a standard, would that be? Would that stand up in coroner's court that we've had that robust process in place and the prescribers give that verbal authority?
Yeah, well, I think you probably need to break it down into a couple of bits. One, if you were talking about that kind of scenario where it was, for anaphylaxis, then you've got the automatic exemption under the regulations that allows anyone to administer adrenaline for anaphylaxis. Not chlorphenamine, I must admit, but you've got certain exemptions that would come into play. I think it would boil down to really yourself and your approach to clinical governance, to be honest. If it came to that, and whether or not you were prepared to stand by that process in a court of law. Because there's nothing in the legislation that would cover that scenario specifically, because like I say, the legislation doesn't cover verbal prescriptions per se. There is a bit around doctors and pharmacists dispensing on the basis of a written of a verbal instruction, but broadly speaking, what you're describing isn't covered by the regulations. So I think it would be down to you to justify your actions probably in a coroner's court.
No,
but hopefully
really
it would never come to a coroner's court.
Well, no. I mean, the thing is, I'm sure many companies here have got clinical oversight. So it's the same for them in respect, is that if you've got a situation where you just need, ones like TXA for major trauma, all these kind of medicines that we use day to day in the ambulance service and the jail, Calcan and the PGDs, when you go into the private sector, it's not really comparable. And I think that's where it's just a bit of a grey area. But I think no matter what clinical oversight you've got, so I think if you've got that kind of, so what you're saying is you've got to have good clinical governance in place, which is great, which is what we should be doing anyway. But actually, as long as you've got that in place and you can stand it up, then it doesn't matter who your clinical oversight is. If they're a prescriber, it gives us that ability to maybe think outside the box a bit. Because again, working in events, the policies don't support us to do so a lot of the time. None of us don't want CQC for many reasons. One, depending on what your company's doing. I don't dispute what the CQC do. I think it's great. But if you're not taking Mrs. Miggins to hospital, I don't understand why you're going to spend £1,500 on registration. But that's another bottle of fish. I think it's the clinical oversight. I just wanted to clarify from that point of view.
I think. I mean, I like I say, I come from an ex-army background, and the number of times that I was aware that medical officers within the army would effectively authorize others to do stuff when technically there wasn't a legal basis for what they were doing. I mean, I remember one medical officer saying about going down to the Falklands where he was basically dishing out bags of Hartmans to basically everyone, and saying if somebody gets their leg blown off, then this is how you deal with it. This was just bog standard infantry soldiers. Technically, there was no legal basis for what he was doing, but if things had gone wrong, would he have been castigated for it? Probably not. And that's really the kind of scenario I think that you're trying to describe, Gareth, is if the need arises and it can be justified and you've got the processes in place to make sure that it's done as safely as humanly possible, then well, basically, unfortunately, you roll the dice and you take your chance. But I personally can't see anything wrong with what you're describing, personally. But unfortunately, there is no legal. There's no legal principle that I can quote to you that'll justify it.
It would be nice if it was just if all the situations could be covered off in writing. That'd be really easy for everybody involved.
And to be honest, this is why PGDs came into being in the first place. There was an awful lot of this kind of activity going on in the NHS and the army and various other emergency scenarios where people were being asked to do stuff that technically they weren't legally entitled to do. So they brought the PGDs in as a way of controlling that process and controlling that structure. Now, yes, like anything, it could do with being amended and brought up to date. We wrote the PGD legislation back in 2003, and to be honest, I don't think even anyone even thought about the concept of event medicine in those days. It probably was happening, but it just wasn't. It wasn't in the sphere of vision for the legislators. So there will always be a chance and a need to bring legislation up to date.
Thanks, Graham. Are there any other questions from anybody that's in the webinar? Just I'm conscious that we've taken up a lot of Graham's evening, but equally that this is good discussion.
Thoroughly enjoy it. But what I would suggest is, if anyone's got any topics that they want to cover off that they think would be of sort of more general interest, I'm quite happy to do this kind of thing, and I'm fairly sure Sam would support that.
Definitely.
If there are topics that you want to address, then why not do it as a group rather than do it in one-to-ones? happy to do this again if you get anything that you feel would be of interest.
I'll just ask Sam a quick question, actually. Sam, are you going to be doing the pre-filled Narcan?
A question for me. That's scary.
Which variety are you after?
Here was me expecting that all the questions were going to be directed at Graham, and I'd got off
for
an easy
on the
ride.
top, Sam.
Potentially, yes. And there's a bit of a chicken and egg.
It's all called.
Yeah, there's a bit of a chicken and egg scenario for us about whether commercially it will be sensible for us to do it, i.e. can we sell it to you, not specifically you, Peter, but can we sell it to our customers at a price at which it's sensible and palatable, and us still cover our overheads, etc., etc. But we can't get a lot of that information until we have our wholesale authorization, but so we need to get that in place first. So I'm going to give a non-committal, not sure at the moment.
We hope answer. Yeah, we paid £22, not including VAT for it at the moment.
Just on the back of
scene.
Yeah, just on the back of that one. And at the moment, the current legislation allows for the naloxone peroxide injection. But what they're looking at is potentially expanding that so that the same provisions apply to the intranasals.
And I think
that's on consultation at the moment. So, you might want to think about, and certainly I think Sam would probably need to think about what his product range included and whether those intranasal delivery systems were part of your requirement as clinicians.
And good news is that we actually sell training nasal naloxone sprays, so that fits quite nicely. But like Ryan's just said in the chat, is that homeless projects, etc., all want the pre-filled. So I imagine it'll be something that we trial, but I just can't say definitively until a point that we've kind of sorted the logistics and kind of commercial aspects of it. Yes, Ryan, we are at ESS. We are Mike 150. So yeah, come and have a chat. We'll be there. Wayne, I'm gonna kind of probably pass over that question a little bit because I'm not sure that is something that Graham can answer unless he corrects me. Is there an appropriate level of qualification to provide clinical oversight? And I think again that's going to come down to your kind of individual
organization governance
and what you're doing and what the risk is and loads of stuff that is kind of beyond the scope of this conversation. Is there any other questions either in the chat or kind of anybody brave enough to speak up? After this, probably tomorrow, we'll get the upload of this available and sent to everybody, and I'll send a PDF copy of the slides as well so that you've got all those links that Graham said. We'll also keep you all updated on when we are actually qualifying customers and
shouldn't be
starting to supply and send stuff out. Just kind of bear with us because we've got a lot of people on a waiting list, so it is going to be a little bit of a kind of trial period to start with, just to iron out any unforeseen issues. A proxy ETA, Sam, that's more a Graham question. I'd hope for saying in sort of the next 8 weeks we'd be at a place that we can submit our app. And thinks I'm being overly ambitious.
No, I think we've got a process that we need to go through, and unfortunately, it's not all in our control. So yeah, we'll do the application, and then it's up to the MHRA to then come and inspect us before they grant the license. Now that's going to be very much dependent on the diaries of the inspectors. I mean, 90 days. It's probably not an unreasonable window to be looking at for that inspection. So, you're probably looking at, I would say, maybe December, January before we're actually in a position with the license, but what we'll do is before that, we'll start doing the testing of the processes. So bringing customers on and setting up the various IT elements, because we need to set up we need to set up product lists and test them to make sure that the right customer, excuse me, the right customers can access the right products and the wrong customers can't access the wrong product, if that makes sense. So there's quite a bit of setup to do.
We are pedaling away in the background, but yeah, we're really keen to get it sorted, and our aim has always been that we can iron out any problems in kind of Q1 of 2024, so that by the time that the majority of the event season kicks off, we're kind of used to the processes and comfortable with doing it. Not overlooking the fact that some of our customers are kind of year-round, frontline services, but we know that this is particularly important, the way that we're doing it to the events sector. But yeah, if you've got any questions or you want to pester me for an update, then please do, and I'll always get back to you. But yeah, please do come and see us at ESS if you're going. Yeah, anything else before we kind of pull this to a close?
Just to say thank you, Sam and Graham, for your time this evening, for your sort of knowledge and expertise that you've shared with us.
It's been really enjoyable. Yeah, I love these debates, to be perfectly honest.
I can give time. I'm not sure that knowledge and expertise applies, Matt, but thanks very much for me. Yeah, like I said, if you've got any questions, please reach out. Graham has agreed that he's happy to kind of set up consultancy type appointments with customers. Those, just to clarify, those would be chargeable for Graham's time, because he's one, a busy man, but two,
I have a day job.
Two, we've got to kind of be mindful of how long these conversations have the potential to go on for, because it is such an intricate area. But I don't think, we don't want to charge the earth and make it completely inaccessible. But I know a few customers I've spoken to have said, actually, you know what, an hour just one-on-one with Graham would be really helpful to iron out some issues that we're having. So, if you want to do that, then please do reach out to myself or Graham. And any questions, just shout and we'll keep you all in the loop. But thank you for giving up some of your evening. And like I said, I'll share with you tomorrow the recording and the slides. Cool. Thank you very much. I will end it there. So I imagine you should get kicked out. But thank you very much for all your time, and enjoy your Tuesday evenings.
Been a real pleasure meeting you all.